today's discussion, that is diabetic ketoacidosis. Uh, this poem, particular poem I found in the textbook of CMC Vellore, where they have described this diabetic ketoacidosis in terms of a poem that describes as sugars are high, they reach the sky, breath smells of grapes, I am under the drapes. My breathing is fast, I hope I will last. Insulin and saline, they are the lifeline. Uh, Pretty well in context, this describes entire diabetic ketoacidosis, what all happening and what the treatment is. So this particular topic is very important both for undergraduates for their exams, postgraduates for their exams, and also in your day-to-day practice. When you sit in an emergency, especially in case of an endocrine emergency or a medical emergency, uh, at least one case of diabetic ketoacidosis is expected in every day of your emergency duty. What many people or what we did was nobody taught us diabetic ketoacidosis in the proper way. We also used to read some charts or whatever things which are given in the internet or some books, etc. But nobody taught the concepts of diabetic ketoacidosis. Only after knowing the concepts clearly while treating the diabetic ketoacidosis, we can manage this particular thing very intelligently. Otherwise, the mortality is going to be very high because each patient is individual. We cannot have a same chart like practice in every patient. This is like what you call an extreme kind of a metabolic abnormality in this particular patient. Patient can present in a variety of uh, metabolic abnormalities or a clinical entity where we need to have a high suspicion towards the diagnosis and during the monitoring of these particular patients. And nowadays, the diabetic ketoacidosis incidence has not gone down. This is still high. Mortality rates have pretty come down in the recent times because of availability of insulin, even rural level of India pretty well. So to introduce today the diabetic ketoacidosis, this is the most common acute hyperglycemic emergency which is associated with type 1 diabetes. The next most common is hypoglycemia, which is an severe hypoglycemia is the next most common associated with diabetes. Whereas we usually say that type 2 diabetes patients are more prone to develop another entity of hyperglycemic emergency, that is hyperglycemic hyperosmolar coma. These two are pretty same things, but with a certain differences in their metabolic abnormalities or the way of presentations and slight treatment in the way we deal with the treatment. Today we are going to discuss about the diabetic ketoacidosis in particular. Uh, Many of you people while going for the exams usually try to by heart that chart from some textbook, usually from Harrison or whatever the textbook. This is because many of the times this is going to be the long question also in your exams. And nowadays the entrance world uh, uh, has got a lot of interest in asking questions regarding diabetic ketoacidosis because of lack of concepts in the students. People tend to only by heart those charts and they don't know what to do when sodium is high, when sodium is low, when potassium is high. We don't know what amount of potassium to give, what amount of insulin to start the patient, etc. So these entirely depends on the basic knowledge which you have in the case of the pharmacology and the biochemistry concerned. So only if you have a proper knowledge, then only you can manage the patient. So this is a pretty frequent one. And if you don't treat this particular entity properly, this is going to be life-threatening patients. Yes, there are deaths due to diabetic ketoacidosis. Although the deaths have come down, the recently the mismanagement have increased the length of the stay of the patients, or the time to recovery has also increased due to mismanagement. Uh, well, we cannot say that diabetic ketoacidosis is completely preventable, but yes, to some extent, with the proper health education towards the patients regarding the treatment and follow-up, it is preventable in some aspect. But even though we have advanced in recent diabetic monitoring technologies, like nowadays we have got CGM devices, we have got newer insulin therapeutics, we have got a pretty long acting now. We are going towards the weekly therapy of diabetes, the insulin nowadays. And even with the insulin delivery system, now we have got a painless delivery systems, we have got insulin nasal inhalers. uh, so much of development has been occurring in the field of diabetes, although the incidence of DKA in both hospital acquired and community acquired section have remained unchanged. So this particular line proves that even though we are developing in a way of monitoring and insulin therapeutics, especially in case of type 1 diabetes, the DKA has remained unchanged. So this is important because even though patients are receiving a very advanced treatment, like some patients are infusion insulin pumps, some patients are having CGM devices, we actually completely cannot prevent these patients from developing DKA. As I said you, the mortality has been low nowadays, but it is generally accepted that the mismanagement after the hospital admission or before the patient has been an important contributory factor. Like in a very bad managed case, definitely the mortality is going to high. Miss some things, the length of stay might have increased, high readmission rates because of lack of knowledge for these patients, and the morbidity is definitely going to high because of an associated uh, cofactors. So hospital management has become very important nowadays. A lot of concerns guidelines, etc. So many associations have given their own guidelines. So many people tend to follow these guidelines strictly. Remember, these guidelines have always been given for the most common people. Those cannot apply for all the people. Like your particular patient may be different from the guideline considered patient. So the patient to patient treatment is going to change. So we need to have a thorough knowledge regarding these abnormalities in these patients. And recently, the adolescent DKA has been a topic of discussion, like 14 to 18 years. Diabetic patients are extremely important because their requirement of insulin during the growth, they have a very high tendency to go into DKA, including type 1 diabetes or including the early type 2 diabetes. We know that nowadays type 2 diabetes can come as early as 15, 16 years because of risk factors or the family history. So these patients are equally exposed to the diabetic keto acidosis. So DKA is not a simple disease. DKA is a very complex disease, and it is an extreme metabolic abnormality. It's not like a mild metabolic abnormality where we can deal the patients on oral medicines or where we can manage the patient in a routine ward. It's not possible. So this is an extreme and a complex metabolic abnormality which should be managed in emergency care setting. So this particular entity in a patient of diabetes occurs due to either absolute or relative insulin deficiency under some stressful condition. So this insulin deficiency is going to be there with this patient as soon as they get the diabetes. Like type 1 diabetes, they have an insulin deficiency. Diabetes have the insulin action deficiency. They are exposed to some amount of stress. Only during that period, they throw themselves into the risk of having diabetic ketoacidosis. So this initially diabetic ketoacidosis was characteristically associated with type 1 diabetes. Like when we were UGs, they used to say that DKA usually occurs only in type 1 diabetes, but it's not so. The type 2 diabetes can also have diabetic ketoacidosis under extreme stresses, like some serious infections, like some trauma, some cardiovascular other emergencies like stroke. And as a presenting manifestation of type 2 diabetes, like usually type 2 diabetes presents asymptomatically. Usually it does not present with severe symptoms, but there is one particular type of or a subtype of type 2 diabetes that is called as ketosis prone diabetes mellitus, which can present the patient directly in diabetic ketoacidosis as a part of type 2 diabetes. So we know that type 1 diabetes can present directly in the DKA. Even a subtype of type 2 diabetes can also present directly with type diabetic ketoacidosis. So we touch this topic later. So how this particular derangement occurs in these patients. So this diabetic ketoacidosis to occur, we need the two basic things here. One is the reduced net effective action of circulating insulin. That is, the insulin is not secreting or the insulin is not performing its action which is supposed to do. And an elevated level of counter-regulatory hormones, usually glucagon, but also accompanied by other stress hormones which have an opposite action to insulin. Like we have got catecholamines, we have got steroids, then we have got norepinephrine, we have got dopamine, we have got growth hormone, etc. So all these acts in a manner which is opposite to insulin. So the reduced decrease in insulin and increase in glucagon is a very basic underlying defect in case of diabetic ketoacidosis, which including these two things, they both combined produces a massive abnormalities in the metabolism of carbohydrates and fats, which leads to a severe dehydration and electrolyte abnormalities, which we are going to discuss later. So we know that insulin and glucagon act in opposite direction. Insulin is a major anabolic hormone in our body. In fact, it is the only anabolic hormone which is significant, while all the rest are catabolic hormones. So insulin, through its action, increases the glucose uptake by the peripheral tissues, especially during the postprandial state. While in the fasting state, they reduces the glucose output from the liver by reducing the gluconeogenesis, and also it increases the storage of fat by inhibiting the lipase. So insulin has a inhibiting effect on lipolysis, whereas glucagon has a stimulating effect on lipolysis. So if you see this particular defect gets exaggerated in case of diabetic ketoacidosis. So there is a massive decrease in insulin glucagon ratio, which shifts the sudden metabolism of the body from the anabolic state to the catabolic state. So there is a breakdown of everything in diabetic ketoacidosis. So why this has to occur in diabetic patients? This does not occur in their routine life. There has to be some predisposing or a precipitating factor for DKA. So usually it is an inadequate insulin treatment or a non-compliance. If the patient is an already diabetic, he has missed his insulin dose, or he has not taken according to his carbohydrate count. And the new onset diabetes, as I said, usually in the case of type 1 diabetes, they can present directly in case of with diabetic ketoacidosis, and there is a subtype of type 2 diabetes, that is ketosis prone diabetes, where the patient can present in DKA. Otherwise, in a pure type 2 diabetes, it is very rare to present them as a DKA. Or some patients have an acute accompanying illness, which is usually an infection, a stroke or a TIA, or a myocardial infarction, or an acute pancreatitis. These can precipitate the DKA in case of pre-existing diabetics. This acute pancreatitis is particularly important because pancreatitis is related to diabetic ketoacidosis in three directions. Like acute pancreatitis can cause DKA, DKA can cause acute pancreatitis, and DKA and acute pancreatitis are two separate diseases which can mimic each other. So it has got all the relations with all in all directions with the DKA. So we need to have a high suspicion in case of acute hyperglycemia with pain abdomen comes. Drugs which can precipitate the DKA. So we know that steroids are definitely the most common drugs which precipitate the DKA. The lesser known drugs are like the second generation antipsychotics, that is usually clozapine, olanzapine, and risperidone. We know that these induce the insulin resistance. These can also cause diabetic ketoacidosis if the patient has been not monitored for their metabolic abnormalities. So patient who is on secondary generation antipsychotics because of clozapine or olanzapine, because nowadays these are the drug of choice for schizophrenia or a psychotic. we need to have the checking of their metabolic milieu every 2 to 3 months, which has been advised by the guidelines also. And cocaine, we know it can cause diabetic ketoacidosis by some reasons, like patient might miss their their insulin dose, or it, as we know that cocaine stimulates the catecholamine secretion, which can induce extreme stress in your body. So lithium, it is a drug of choice for bipolar disorders. So lithium can also cause diabetic ketoacidosis by inducing the insulin resistance. So another point which you can remember here is lithium is also responsible for diabetes insipidus, that is usually nephrogenic diabetes insipidus. So lithium is a one drug which can cause both diabetes insipidus and diabetic ketoacidosis. And nowadays we know that SGLT2 inhibitors are the center point in case of type 2 diabetes. Whereas in some countries, these SGLT2 inhibitors are used as off-label in treatment of type 1 diabetes, which is like FDA has given a strict warning that it should not be used in case of type 1 diabetes. In spite of this advice, many countries use SGLT2 inhibitors for type 1 diabetes, which is a very dangerous thing. They are definitely exposed, or definitely their euglycemia you cannot achieve with SGLT2 inhibitors in case of type 1 diabetes. And these are particular risk factors in developing diabetic ketoacidosis. And the sympathomimetics like terbutaline and the salbutamol can be a causative factor in case of diabetic ketoacidosis. Usually when we use it for our respiratory illnesses, in the doses, which are we using very low doses, or we'll be using in divided doses, which is usually does not cause DKA. Whereas if the terbutaline is usually used in case of a preterm labor to induce uterine in what you call to reduce uterine contraction as a tocolytics, they are used as a subcutaneous infusions, where the incidence of diabetic ketoacidosis is very high, especially if the patient or a pregnant woman, they are having a gestational diabetes or a chronic diabetes. So terbutaline, salbutamol, when we use in a respiratory diseases, we are not expected to monitor the patients on the hyperglycemia or diabetic ketoacidosis. Whereas if the patient, we are giving the salbutamol infusion or a terbutaline continuous infusion or subcutaneous intermittent injections, we are supposed to monitor the patients for development of diabetic ketoacidosis. So as far as entrance world is concerned, yes, the most common cause or a most common precipitating factor in case of DKA is infection. So if you particularly want to know which infection, it is either a pneumonia or a urinary tract infection. So you will be given either of them as an option as a most common precipitating factor. So you can choose either of one. So either pneumonia will be given or a urinary tract infection. The second most common is diabetes presenting with DKA. So many of the people tend to go towards the inadequate insulin treatment or the non-compliance as the most common cause. No, I have given the statistics also here. The most common cause is an infection. The next second most common is diabetes presenting directly as a new diabetes with DKA. So we know that DKA has got three basic abnormalities, that is an hyperglycemia and a ketosis and an acidosis. Although the hyperglycemia is not a must in having diabetic ketoacidosis, diabetic ketoacidosis can definitely occur even without hyperglycemia. Like patient can have a euglycemia, yet patient can have ketosis and acidosis. We will discuss that later. We know that whenever we encounter a patients of ketosis or acidosis, we need to have the differential diagnosis ready. So we always need to know other causes of the existing things also. Ketosis we see in a case of extreme fasting conditions and alcohol overdose, etc. And we know that acidosis has got many number of causes. And in case of hyperglycemia, we know this can be a stress type hyperglycemia because of steroids or because of COVID. A lot of things are involved here. So we need to have a differential diagnosis ready. And we always tend to have an alternate diagnosis. The patient is not fitting the criteria. So the basic spectrum of abnormalities in case of DKA, we have got metabolic abnormalities here. The first is obviously hyperglycemia. As I said, it is not must, but it is a most common association, that is hyperglycemia. Then ketone production, which leads to high anion gap metabolic acidosis, which has got a lot of abnormalities in plasma osmolality, plasma sodium level, and plasma potassium level. Along with the metabolic abnormality, diabetic ketoacidosis is a pro-inflammatory state. This is very important. There is a lot of oxidative stress during the diabetic ketoacidosis, as there is a generation of huge amount of reactive oxygen species. So we are going to discuss these abnormalities each in detail. So from this point of time till the end, I want the students to have a very high concentration here. You need not remember anything. You just remember the basic concept. Everything is from the biochemistry or the physiology which you have learned earlier. Hyperglycemia. Why this hyperglycemia occurs, we know. See, whenever you see a diabetic ketoacidosis patient, the blood sugar level is usually high. So your glucometer may show directly as the high. High from the glucometer varies from machine to machine, but usually it says more than 600. But generally, the level of hyperglycemia does not go above 800 in case of DKA. There might be an extreme hyperglycemia, like your blood sugar may go above 1000 milligram per deciliter, which is rare in case of diabetic ketoacidosis. Often we see the hyperglycemia range in case of 350, 450, 600, 700, etc. But that doesn't mean that glucose level cannot go above 800 in case of DKA. There have been the case reports also, and till now, according to me or whatever I have gone through the literature, the maximum amount of hyperglycemia that is published is 1800 milligram per deciliter with diabetic ketoacidosis, and lowest that is published is 103. So even with euglycemia, as I said, you patient can have the ketoacidosis. The hyperglycemia level varies. Usually it is between the range of 350 to 450. So why this hyperglycemia occurs in extreme condition? As I said you, there is a decrease in insulin secretion or action, along with the increase in counter hormones, which leads to three basic fundamental abnormalities here. Like one is the glucose cannot be utilized by the peripheral tissues. Without insulin, your skeletal muscles and adipose tissue cannot take the blood from the, they cannot take the glucose from the blood. And if there is no insulin, the liver is going to produce a lot of glucose from the gluconeogenesis, and there is a breakdown of glycogen into glucose, which spills to the blood. So there is an extreme catabolism occurring in the body. So all the glucose which is stored comes to blood, and all the glucose which is there in the blood cannot be utilized, which leads to an extreme hyperglycemia. So although basic fundamental thing is same in both HHS and DKA, the level of hyperglycemia is different. The reason, we need to know the reason, because why usually we have the patient of HHS going blood sugar level more than 1000, whereas it is pretty like in the high, moderate to high level in case of diabetic ketoacidosis. It is because HHS patients, they tend to be very elderly age group. Usually they have an accompanying kidney dysfunction. So body always try to maintain homeostasis. Whenever there is a lot of glucose in the body, the kidney tries to excrete as much as glucose as possible. We know that the renal threshold is 180. If this threshold is crossed, the glucose starts appearing in the urine. As the DKA patients are younger than HHS, they have got a capacity to excrete excess of glucose in their urine, which leads to osmotic diuresis and also dehydration. Whereas HHS patients usually have an underlying some kidney dysfunction where the amount of glucose excretion cannot meet as much as that occurs in DKA. So this is a particular reason where HHS tend to have a very high glucose level compared to diabetic ketoacidosis. So what happens during this diabetic ketoacidosis is we know that there is a lot of glucose in the body or in the blood, but cells cannot utilize it. So it's called as the scarcity in the midst of plenty. That is what is diabetes. We have so much of glucose, but your skeletal muscles cannot use this particular glucose to produce energy. So the body tries to compensate by increasing the fat destruction. We know that insulin inhibits lipolysis, as I said you in the previous discussion. The insulin inhibits lipolysis. If there is no insulin, the lipolysis is going to increase. This action is brought up by involving one particular enzyme, that is hormone sensitive lipase, which is very sensitive to insulin. So if there is no insulin, increased action of hormone sensitive lipase. So this lipase particularly breaks whatever the triglycerides that are stored in case of your adipose tissue. So these triglycerides are broken down into free fatty acids and glycerol. So these free fatty acids, which are broken down, get transported to the liver. We know that liver is a major metabolic organ, and in the liver, these free fatty acids are undergo beta oxidation into formation of acyl coenzyme A and ultimately forming an acetyl coenzyme A. So we know that an acetyl coenzyme A has got the three ends. Acetyl coenzyme A can enter, in case of an oxidative metabolism, it usually enters a Krebs cycle where it ends up producing ATP. We know this. If in a case of low insulin in your body, this acetyl coenzyme A cannot enter Krebs cycle. Instead of entering into Krebs cycle, it enters the ketone cycle where it undergoes beta oxidation to form a ketone body. We know that there are three types of ketone bodies which can be produced in a human. That is an acetoacetate, which can then be converted into beta hydroxybutyrate and acetone. So this particular thing leads to a massive production of keto acids in the body. So this increased production of ketones leads to ketonemia. These starts appearing in the blood. Liver cannot hold the amount of ketones produced. So these ketones try to provide an alternate source of energy when the glucose availability is reduced. Although it cannot match glucose, but it tries to do its purpose. So this is the basic mechanism. These acidosis then. So we know that ketosis, there is a production of keto acids. So by name itself, these are keto acids, especially the acetoacetate and beta hydroxybutyrate. These are the keto acids, whereas the acetone is a non-acid variant of ketone. So these acetoacetate and beta hydroxybutyrate accumulate in the body, increasing the amount of acids. So this increased production of and accumulation of the hydroxybutyrate and acetoacetic acid in the body causes metabolic acidosis. So this particular type of metabolic acidosis, which occurs in case of diabetic ketoacidosis, is called as high anion gap metabolic acidosis. We know that as an UG, you might have a very difficult understanding of the concept of anion gap. I have made a simple thing here. These are called Gamble grams. These are discovered from John L. Gamble, who was a pioneer in imbalance. These are very easier thing while understanding acid-base balances. So to know what is anion gap is the amount of unmeasured anions in your body. We know that body always try to have a homeostasis. So the number of positive ions is usually equal to number of negative ions. But we cannot measure all the negative ions in the body. Whereas major positive ion in our body is sodium, although potassium to some extent. The cellular is sodium, the major anions which we can measure are chloride and bicarbonate, whereas the anions which we cannot measure is what we call it as anion gap. So normally the cations have an equivalence with the anions in your body. So what is this anion gap? This anion gap is serum sodium minus the anions, that is the measure serum chloride level and serum bicarbonate level. So what happens in high anion gap metabolism? So there is a lot of production of these unmeasurable anions by the body during ketoacidosis. So body tries to do the buffer of these extra acids by consuming the bicarbonate. So bicarbonate decreases because of the buffer activity. So ultimately increasing this anion gap, decreasing the level of bicarbonates in our body, which causes this particular high anion gap metabolic acidosis. Whereas there are other types of metabolic acidosis, that is non-anion gap metabolic acidosis, which is basically due to increase in the chloride in the body. The anion does not increase, but the chloride amount gets increased because of hyperchloremia. So the anion gap remains same. So this is particular entity is called as non-anion gap metabolic acidosis, which is usually seen in case of renal tubular acidosis. Whereas all the metabolic aspects like lactic acidosis, early stage of an acute kidney injury, or metabolic keto acidosis, a lot of poisonings can cause this high anion gap metabolic acidosis due to accumulation of inorganic acids in the body, which adds to this component, that is unmeasurable anions, which causes increase in anion gap. So this amount of the acidosis and ketonemia is not similar in all the patients. It depends. Basically, it depends on the rate of production of ketones, the rate of metabolism of ketones, and the rate of loss of keto acids in the urine, and the volume of distribution of this keto acid anions, and the rate of renal net acid secretion. So there are a lot of factors deciding how much amount of acidosis is going in your body, how much bicarbonate is consuming. So it varies from patient to patient. So as I said, the basic abnormalities are the hyperglycemia, ketone production, and the increase in anion gap leading to metabolic acidosis. We know that the glucose is going to accumulate in the blood, which increases your serum osmolality. Although this serum osmolality in case of an HHS, because definitely hyperosmolar, but usually the cases in case of DKA, as I said the glucose concentration in the blood may not be too high as compared to HHS. The amount of hyperosmolarity seen in DKA is definitely lesser than that is seen in HHS. We should know the relation between glucose and the sodium level. So this hyperglycemia rises the ECF, the extracellular fluid osmolality. This is an osmotically active substance which draws the water from intracellular compartment, causing dilution of your intravascular compartment. So this will lead to the dilutional hyponatremia. So there is a definite equation that for each 100 increase in glucose, the serum sodium falls between 1.6 to 2.4. In between this range, the serum sodium falls. So we need to have corrected sodium for these patients whenever we get the lab reports. Whatever we are seeing from the lab report may not be actual sodium. Actual sodium may be much lesser than this. So every 100 increase in blood glucose drops your serum sodium by 1.6. The 1.6 is a particular number which is given in Harrison, even in 21st edition. But there are studies that it is not same for each person. It can vary from 1.6 to 2.4. And nowadays the guidelines are saying to use the 2 milliequivalents of liter fall average of these two. And we know this excessive hyperosmolarity and hyperglycemia lead to osmotic diuresis, which also adds to this dilutional hyponatremia. So the basic abnormalities in the case of ketoacidosis is hyperglycemia, the ketone production, anion gap metabolic acidosis, which ultimately leads to the increase in plasma osmolality. And the basic metabolic abnormality or a pathophysiological abnormality is reduced insulin and increase in the glucagon or associated counter-regulatory hormones. So, what this is going to our body? So, the extreme hyperglycemia will have the symptoms of polyuria, polydipsia, and weight loss. We know, and due to extreme hyperglycemia and extreme what you call hyperosmolarity and metabolic acidosis may cause you neurological symptoms like patient is lethargic, patient is dull looking, patient might have an obtundation. In rare cases, patient may have seizures. Uh, Patient can also have a focal neurological deficits. This is particularly important in case of an HHS. The neurological symptoms are very common due to hyperosmolarity in case of HHS as compared to DKA. Now coming to the most important symptom, that is abdominal pain in diabetic ketoacidosis. This is a very important symptom. If you sit in an emergency, any type 1 diabetic patient coming with a pain abdomen, the first thing you need to rule out is diabetic ketoacidosis. This is a very common symptom, usually not seen in case of hyperglycemic hyperosmolar coma in old patients, whereas in diabetic ketoacidosis, the abdominal pain has been a very important symptom. Till now, we cannot prove why this particular abdominal pain. There have been studies which tells that there are multiple reasons involved, like there is a delayed gastric emptying and there's ileus due to metabolic derangements like an acidosis, hypokalemia, which induces the ileus or a subacute intestinal obstruction. And there is a rapid expansion of an hepatic capsule which can cause pain. And sometimes there is a mesenteric ischemia due to volume depletion. Many of the times they usually mimic acute abdomen and they end up in surgical emergency. After diagnosing hyperglycemia, they might shift the patient back to medical emergency. So such a level of confusion it creates. So the patient usually have a severe pain abdomen in case of severe acidosis. So this particular abdominal pain had a correlation with level of acidosis in one study, with hyperglycemia. So hyperglycemia does not define the severity of diabetic ketoacidosis, whereas the level of acidosis will define the severity. And acute abdomen, only after the resolution of this ketoacidosis, even if your pain is not reducing, then you should think of other causes like pancreatitis or mesenteric ischemia or other things. And patients usually have a normal body temperature or mild hypothermia regardless of presence of infection. Even though your patient does not have any fever, you always have to rule out an infection by actively searching for it. Just by absence of fever does not rule out accompanying infection in a patient of diabetic ketoacidosis. And on physical examination, you see the signs of dehydration like decreased skin turgor, dry axillae, and dry mucous membranes, low JV pressure. There might be tachycardia, hypotension, and sometimes patient may be in frank shock. And this particular sign is everybody know that the patient, due to excretion of ketones, they smell like a fruit due to exhaled acetone. As I told you, acetone is not an acid, so excessive acetone can be excreted in your breath, so which gives this characteristic smell in your breath. So this is a fruity odor. If you want to know exactly how this diabetic ketoacidosis patient breath smells, you need to have the smell of the nail polish remover. That is how exactly they smell. That is acetone in the nail polish remover. We know that Kusumal's breathing because of an acidosis. There is a compensatory hyperventilation. Body tries to remove carbon dioxide by increasing the drive, which causes rapid and deep breathing, which is particularly known as Kusumal's breathing. And as I said you, the neurological abnormality can vary from mild confusion to deep coma. But this is particularly important in case of hyperglycemic hyperosmolar coma in type 2 diabetes. So as soon as we suspect diabetic ketoacidosis or diagnose diabetic ketoacidosis, we need to have particular initial laboratory evaluation of these patients with the serum glucose, serum electrolytes, along with the calculation of ANAP. Nowadays, we have got point of care testing machines where if you give immediately within 1 or 2 minutes, you are going to get the electrolytes, some good machines. And we need to have CBC with differential count. Then we need to measure the amount of ketosis which is happening in the body by the urine analysis and the serum ketone analysis. As I said, the ABG analysis is important, and ECG is must to have the potassium changes in the initial time. So additional testing depends on the patient and need basis. If you're suspecting some infection, like if you're suspecting pneumonia, you can go for chest X-ray. If you're suspecting urine infection, you can go for blood culture, urine culture, etc. If you're suspecting pancreatitis, you can go for amylase. So the need basis investigation goes on. HbA1c measurement also becomes important because you will get an idea about what level of glycemic control patient is having for the last 3 months. So serum glucose, as I said you, usually go in the range of 400 to 600 in case of dose, but it can goes to extreme level. Even in case of some patients, it may be normal, or in case of some patients, it may go about 1000. So this euglycemic diabetic ketoacidosis is a particular interest nowadays. Here, the serum glucose is normal or near normal, which can be seen in patients who have the poor oral intake, or the patient have received the insulin prior to arrival in the hospital. Like if the patient has gone to secondary care hospitals or referring hospitals, they usually give a shot of insulin IV before sending these patients. So which might bring the glucose down, and many of the patients may have hypoglycemia as soon as they land up with you. And this SGLT2 inhibitors have been the main culprits in case of euglycemic DKA. This has been the hot favorite. Like by the time now, everybody is knowing that SGLT2 inhibitors are important for causing euglycemic diabetic ketoacidosis. The measurement of ketones is very, very important. The three types of ketones, as I said you, the acetone, and two types of the keto acids, that is acetoacetate and beta hydroxybutyrate. So in case of the diabetic ketoacidosis, the beta hydroxybutyrate is the main serum component which we usually see. So whatever the urine ketone which you usually see in case of your emergency, urine ketone dipsticks, they test this method by the nitroprusside method. So this nitroprusside method usually tests only for acetone or acetoacetate. So in majority of the patients, the main ketone which we see in case of diabetic ketoacidosis is usually beta hydroxybutyrate. So if this nitroprusside cannot detect, so there is a chance of patient denying the diagnosis of diabetic ketoacidosis as this test comes negative. So this is this we usually tell as false negative. In some cases, I will say in many cases, especially in severe DKA, the ratio of beta hydroxybutyrate to acetoacetate may go about 10:1, where the nitroprusside or a urine dipstick may fail to show the positive report. Some drugs have been given bad names, captopril, penicillamine, and mesna, mainly because of their groups. They cross-react and they may come as a false positive. And a persistent positivity is a very important thing, because after successful this beta hydroxybutyrate gets converted back to acetoacetate, which gets excreted in the urine. Resolution, the nitroprusside keeps on detecting that although patient is in remission or a patient has been out of diabetic ketoacidosis, so which might confuse you with your treatment. So this prolonged positivity is usually seen with these negative dipsticks. So this negative dipstick, nowadays it's been bleak in the practice. Nowadays we have got direct ketone meters. I have shown you this picture. This particular device can directly detect the amount of ketones through your blood, as similar to your random sugar, which we usually check with glucometer. And I have shown you the number also, the 4 millimeter per liter, 4 millimoles per liter. This is actually the criteria to tell the patient having ketonemia. It should be about 3. So nowadays, there is a shift from urine dipstick to ketone meters. This is very important because many of the hospitals still now depend on urine dipsticks. Nowadays, we have got point of care testing available for ketone meters. So we need to measure what is the anion gap and what is the amount of metabolic acidosis going on in the patient. As I told you, the serum anion gap is a difference between the measurable cations and the measurable anions. So as soon as the electrolyte report comes, we can have anion report with us. So this in this particular entity, the serum sodium which we use, it is to be taken from the actual measured plasma concentration and not the corrected sodium. The many of the postgraduates in the emergency do the wrong thing. Even when I entered MD medicine in the first year, I was told that corrected sodium used to be used in this particular calculation. As I told you that every 100 increase in glucose decreases your serum sodium by 1.6. So the corrected sodium concentration we're going to calculate for these patients. But while measuring the anion gap, we need to use the serum sodium which is being given in the actual report. And the serum bicarbonate is usually moderate to markedly reduced in case of DKA. I told you this is a metabolic acidosis. So the bicarbonate is definitely going to be low, and anion gap is usually greater than 20. We have got a normal range of 3 to 10. And this metabolic acidosis, as I said, you is compensated in the respiratory department by the hyperventilation, which reduces your PaCO2. And if the hyperventilation cannot occur, if it is compromised, for example, if the patient's sensorium has been altered, patient cannot breathe properly, the pH can be very low, like it goes below 7, which can cause sudden death of these patients. And another confusion many of the people have is, in some books, they give serum sodium plus potassium minus anions. See, the American-based equations always have only serum sodium, whereas Europe and Australian-based calculations have got serum sodium plus serum potassium. Although the concept is changed, the concept is same here, but if at all we are using serum potassium with this, the anion gap may come a little bit higher than what we use without potassium. So as I told you, these Gamble grams are very easy in understanding the concept of anion gap. Normally, I told you the amount of anions, cations is equivalent to an amount of anions, and whatever the amount of anions which we cannot measure is being calculated as anion gap. In case of diabetic keto acidosis, as I said you, there is a generation of huge amount of acids where the bicarbonate gets consumed, and this anion gap increases. So as the anion gap increases, there has been a definite relation between the increase in anion gap and the decrease in bicarbonate in these patients. Like the amount of increase in anion gap is equivalent to amount of decrease in bicarbonate. So there is a if amount of increase in anion gap does not relate with the decrease in bicarbonate, then we need to know what is the delta gap in these patients to assess the coexisting other abnormalities. So the concept of delta gap is very important. As I said you in simple terms, we know that anion gap is going to increase in a diabetic ketoacidosis and bicarbonate is going to decrease. But we need to know what is the relation between that, whether this is equivalent relation or not. So for that, we can calculate the delta gap, or even we can calculate the delta ratio. So delta gap is basically anion difference in the anion gap minus difference in the bicarbonate. If you take the difference, it will become delta gap. If you take a ratio, it is delta ratio. The concept here is same. Don't get confused. Many of the textbooks give delta gap, many of the textbooks give delta ratio, but the concept remains here same. So if the difference is 0, like the increase in anion gap and the decrease in bicarbonate are equivalent, yes, this is a pure or isolated high anion gap metabolic acidosis. Whereas if the delta gap is positive, like increase in anion gap is more than the decrease in bicarbonate, that means the bicarbonate has accumulated in your body through another condition or another abnormality. So that is usually a metabolic alkalosis. If the delta gap is negative, that increase in anion gap is lesser than the decrease in bicarbonate. So there is an accumulation of another extra anion, that is chloride, in the body via the non-anion gap metabolic acidosis. So this is very, very important. If the delta gap is positive, so there is coexisting alkalosis going on in your body, and if the delta gap is negative, there is a coexisting non-anion gap metabolic acidosis along with the high anion gap metabolic acidosis through two different entities. This is one, and we need to monitor this anion gap and delta gap throughout the patient till complete. Many of the treatment things are going to alter, and many of the things which we use as a treatment can induce the electrolyte abnormalities in these patients. So let me take some examples here. So if you take an example one, here there is a 60-year-old gentleman with type 2 diabetes who is admitted with a fever and hypertension. And if you get the reports, that is pH comes as 7.3 and sodium is 137, chloride is 97, and bicarbonate is 20. So if you calculate the anion gap, that is sodium minus chloride plus potassium, the anion gap comes 20. So it is definitely higher. So this patient is having a high anion gap metabolic acidosis. So now we should know whether this is a pure high anion metabolic acidosis or there is a coexisting abnormality. We need to calculate the delta gap. As I told you, the delta gap is the difference in the increase in anion gap and decrease in bicarbonate. So here delta gap is 4, that is positive. So since the delta gap is positive, so there is a coexisting metabolic alkalosis. So this patient is having a separate disease here. So we need to address this issue also. This can be anything. Patient may have a diuretic use, patient may have an associated Cushing syndrome, patient may have an associated what you call sepsis, patient can have a respiratory pneumonia. Many things can cause. Patient may be given a diuretic before coming to hospital, which can cause metabolic alkalosis. So we need to always have the other diagnosis ready. As for another example, a 16-year-old female with type 1 diabetes who is admitted with the diabetic keto acidosis shows that the pH is 7.25, the sodium is 155, the chloride is 125, the bicarbonate is 15. So if you calculate the so definitely is so there is a high anion gap metabolic acidosis. So now we want to know whether the gap or not. So to calculate the delta gap, the difference in anion gap and the difference in bicarbonate is calculated. Here the delta gap is negative. So since the delta gap is negative here, so we need to suspect the patient is having, along with the high anion gap metabolic acidosis. In case of an excessive sodium chloride infusion, patient hyperglycemia induced non-anion gap metabolic acidosis, metabolic acidosis. If the doctor does not fluid to give, he might have given excessive fluids for these patients, especially when he has not taken weight into the consideration. Especially these diabetic patients are thin belt type 1 diabetics. We usually end up in giving high amount of ketone in the picture. So I think I have cleared the concept of delta gap here. Next, we need to measure the serum sodium. As I told you, the measured sodium may be different. We need to correctly know what is the actual sodium status in our body. So, as I told, for corrections, the sodium 1.6 for each 100 mg. The fall is usually by 2 milliliters, by 2.4 also. So, in recent years, the value of 1.6 might change to 2, but till now we are using 1.6 for the calculation. Even the Harrison 21st edition is giving 1.6. So I want everybody to remember, even for your exams, that serum serum potassium. This is a very particular thing of interest in case of diabetic ketosis management. If you don't address the potassium, if you don't know how to manage potassium, believe me, your patient is going to suffer a lot. Even you will lose your patient, because this is a very deadly metabolic disturbance which can encounter It can cause a sudden cardiac death by inducing ventricular arrhythmias if you don't address the potassium issue properly. So overall, a diabetic ketoacidosis is a state of potassium deficit, where the total body potassium deficit may be very high by 300 to 600 milliequivalents, because we know that there is a lot of osmotic diuresis is going on. We are losing the lot of fluids. So this, along with fluid, the electrolytes also gets lost. So the major in the case of diabetic ketosis is because the ketones are usually bound to potassium rather than sodium. So the potassium usually lost along with the ketones in case of urine. Although there is a huge total body deficit of potassium, if you see the lab reports, the serum potassium comes pretty normal, like it may not be very low. This is because we know that there is a deficit of insulin. We know that insulin is a very important in case of redistribution of potassium. In case of low insulin, the potassium is going to shift from the intracellular compartment to the extracellular compartment, say for the drop in total body potassium. So only 5% of patients tend to have the hyperkalemia in the lab report, that is serum potassium less than 3.3 is only in 5% of cases. Whereas in the rest of the cases, the potassium may be pretty normal, although body potassium is very low in these patients. So another important thing is you are going to start your patients of DKA on insulin. So after insulin, this significant shift will become opposite. Like after starting insulin, all of the potassium which is there in the ICF will enter into the intracellular compartment, which exposes this total body deficit of potassium. So first report of your potassium may be showing 4.2, 4.3. As soon as you start insulin patient, the next 2-hour reading may comes 2.2, 2.3. Patient may die if you don't care. And I have given a note here, serum potassium. If you have any doubt, serum phosphate, if you have any doubt in case of diabetic ketoacidosis, the serum phosphate behaves exactly as serum potassium. So whatever the thing I have written here, you can just replace potassium with phosphate to know what is happening with the phosphate. There is a huge deficit of serum phosphate. Although insulin can shift this phosphate from ICF to ECF, there is low insulin. There is an opposite thing which is happening. There is a lot of shifting of this phosphate from ECF to ICF in case of low insulin state. The serum amylase and lipase needs a separate mention in case of diabetic ketoacidosis, because as I told you that acute pancreatitis can precipitate or it can also complicate the diabetic ketoacidosis. We know that diabetic ketoacidosis, there is a lot of lipolysis which is happening, especially the diabetic dyslipidemia that depicts a very high amount of triglycerides in the body. If you have a diabetic dyslipidemia associated with diabetes, especially in a case of acidosis state, there is a rapid rise in triglycerides in your body in some patients, which can cause triglyceride induced acute pancreatitis in these patients. So this diabetic ketoacidosis, hypertriglyceridemia, and acute pancreatitis are can coexist in a similar patient. And also, as I said you earlier, a pre-existing acute pancreatitis can precipitate an attack of diabetic ketoacidosis in the patient. So it is very difficult to distinguish between these two, whether the acute pancreatitis is a causative thing, or if the patient abdomen is because of pancreatic thing, or it is only because of this diabetic ketoacidosis. So we usually measure amylase and lipase to rule out or to prove the acute pancreatitis in our patient. But this does not apply in case of diabetic ketoacidosis, because the serum amylase and lipase can be seen rise in case of diabetic ketoacidosis even with any evidence of pancreatitis. This is because the reason is actually not known. The non-specific amylase elevation is being seen mostly from the salivary origin, but also pancreatic origin has been seen. The lipase can be seen very high in case of diabetic ketoacidosis. And also the rise in this amylase correlates with the pH or acidosis, while the rise in lipase correlates only with plasma osmolality, but not with the acidosis. So this can be an entrance question in a future part, especially in case of AIMS related questions. the rise in serum amylase or non-specific rise in serum amylase correlate with both level of acidosis and the osmolality of the plasma. Lipase correlate only with plasma osmolality but not with the acidosis. But the reason is not known why the lipase usually high or why some amylase is high. The reason is actually not known. Therefore, if you actually want to know whether the patient is having acute pancreatitis or not, so you should actually go for the imaging here. So CT will help in differentiating whether the patient's rise in amylase is because of diabetic ketoacidosis or because of pancreatitis here. So we know that this is being so diabetic ketoacidosis severe depending on the level of acidosis. So the plasma glucose of blood glucose of 800 in a patient of diabetic ketoacidosis not going to change anything. Going to alter your treatment. So the serum glucose criterion for DA is 250. Anything less than 250 with ketoacidosis we are considered as euglycemic ketoacidosis. Anything more than 250 with ketoacidosis we are going to consider as hyperglycemic ketoacidosis. And the pH should be less than 7.3. The bicarbonate should be less than 18 according to American Diabetic Association here. And urine ketones can only be depicts like 1 positive, 2 positive, 3 positive, whereas serum ketones can actually measure the amount of ketones, and the amount of ketones also depicts the severity of the diabetic ketoacidosis along with the anion gap. So the entrance question may come like this: which among this does not define the severity of diabetic ketoacidosis? An option can go from the pH, the bicarbonate, the anion, and blood glucose. So blood glucose does not ketoacidosis with varying degree of hyperglycemia. The treatment is not going to change, whereas a drop in acidosis is definitely going to change the treatment. An alteration in sensorium is dependent again on acidosis. If there is a very severe acidosis, the patient is going to have a stupor or a coma. Although these neurological symptoms, as I said, are very important in case of HHS. Now coming to the treatment aspect, believe me, treatment aspect is very easy in case of diabetic acidosis, only if you know the basics right. If you by heart the charts which are given to the guidelines, you are going to have a memory loss over a period of time, and when actually patient comes, you don't remember anything. So the basic concept of this management of diabetic ketoacidosis is under the headings of this. First and foremost thing is the fluid resuscitation, and the next is insulin therapy. Believe me, the first two are the very most important thing. Even if you don't do anything, if you do the first two things properly, the patient is going to come out of DKA very soon. The third most important is the correction of acid-base imbalances and the correction of the electrolyte abnormalities and the treatment of precipitant and the comorbid condition. So the most common cause of death in case of the diabetic ketoacidosis or a case of the hyperglycemic coma is usually the comorbid condition. The patient may be having an accompanying MI or an accompanying stroke, etc., which are usually the direct cause of death. Whereas if the patient is dying due to because of first four causes, this definitely predicts or proves the insufficiency of the treating doctor here. So the first and foremost thing is fluid resuscitation. This is a very important aspect in case of DKA. The patient may have a total body water deficit of around 6 liters in case of DKA, whereas in case of an HHS, it may be around 10 liter, 12 liter. And the main treatment is the intravenous solutions to replace whatever the fluid or electrolytes which you have lost. That is what the treatment is. And just by replacing an adequate intravascular fluid, you are going to achieve a significant euglycemia and acid-base balance here in these patients. So the first thing is fluid resuscitation. So when this fluid resuscitation comes, the next thing is you should remember is fluid of choice. Which fluid? And the next, how much of fluid? That is what the question is. So fluid of choice. So although we know that colloids have a theoretical benefit of increasing or holding the osmotics in case of intravascular compartment, there are no motility benefits with the colloids, and although they're very costly, you cannot use H-starch, albumin for every patient of diabetic ketoacidosis, which is very costly. So the fluid resuscitation, the fluid of choice in this particular category is the crystalloids. So among the crystalloids, the balanced isotonic solutions, that is either an 0.9% normal saline or the Ringer lactate. Although my own preference is towards the 0.9% normal saline in the initial category. Many of the institutes, they have got their own preferences. Some may prefer Ringer lactate or 0.9% NS, but you can use either of one, but preferably 0.9% NS. So the first decision which you are going to take the patient as soon as you diagnose them on DKA is put the patient on 2 large bore IV cannulas and start the patient on fluids. What fluid? As I said you, normal saline. How much fluid? This patient's hydration status. If the patient is in shock, if the patient has not passed urine, if the patient is having a central pressure of like systolic of less than 190, if the patient has got cool clammy peripheries, the patient is in shock. So you know the shock level of treatment here, like push the patient 30 ml per kg of the fluid for the shortest possible time. This is what the shock guidelines. This is same irrespective of all the things. Like if the patient is having acute gastroenteritis shock, you are going to push this amount of fluid. If the patient is in shock, this amount of fluid you are going to push. So it's the same for DKA. So if the patient is in shock, you are going to push 30 ml per kg. This is even true for a septic shock. You are going to push the patient of 30 ml per kg. So if a patient is of 60 kilo, the average of 900, like 1086 into 3800 ml of fluid should be given, whatever the shortest possible time with the large bore needle as possible. If the patient is not in shock, then you have to remember one number, that is 50 to 20. So this is the amount of fluid per kg. 15 to 20 ml per kg per hour for the first couple of hours. If the patient is not in shock, you are going to give this much of fluid. This is very, very important. I have given you an example of an average adult here. So this is what we usually give the nursing staff order in case of diabetic ketoacidosis. We tell them to push 1 liter of saline over 1 hour, next 1 liter over next 2 hours, and next 1 liter over next 2 hours. So for the first 5 hours, we are giving 3 liters of normal saline. So, but we need to have a weight-based management. As I told you, some patients may be overweight, especially in case of type 2 diabetes, and some patients may be underweight, especially in case of type 1 diabetes or children's. So we need to have a 15 to 20 ml per kg for the first couple of hours. After third to fourth hour, the picture may change. Your glucose become normal, so you may replace your normal saline with dextrose, or your sodium may be very high, so you will shift the patient from 0.9 to 0.45% NS. That goes on changing, whereas the initial fluid of choice is always normal saline at the rate of 15 to 20 ml per kg, and if the patient is in shock, 30 ml per kg. Potassium replacement is very, very important here. As I said you, the patients of diabetic ketoacidosis have a very large amount of total body potassium deficit. So before starting the patient on treatment, you need to have a serum potassium value in your hand, and this serum potassium value depicts the treatment. Here you have to remember two numbers, that is 3.3 and 5.3. If the patient's serum potassium is below 3.3, remember, if the patient's serum potassium is below 3.3, you need to manage this patient very aggressively, because patient is having hypokalemia, that is marked hypokalemia. Patients are very prone to have a cardiac arrhythmias here. You need to correct this potassium as rapidly as possible with a 22 milliequivalent potassium per hour. This to be given with a central line inserted. This amount of potassium we cannot push through the peripheral vein. We need to have a central vein for. And if the patient has along hypokalemia also has a cardiac changes, like has a marked hypokalemia, Patient requires very aggressive, sometimes requiring more than 40 milliequivalents per hour, and you need to correct it very rapidly. If the initial serum potassium is normal, serum potassium is 3.3 and 5.3, for every 1 liter of replacement fluid you are giving, adding it to the 30 milliequivalent of potassium, that is usually potassium chloride, and adjust potassium in the 4 to 5. This is very, very important. As everybody of us know that hyperkalemia is more dangerous than hypokalemia. Diabetic keto acidosis is the only picture where we are giving IV potassium even if serum potassium is more than 3.3. This is very, very important. Here the cutoff is 5.3 and this is a standard cutoff. This is not my own thing. If the serum potassium is less than 5.3, for every liter of fluid you're pushing, you need to have a 20 to 30 milliequivalent potassium chloride in it. If not, what happens is, as I said you, the next treatment we are going to give the patient on insulin. As soon as the patient starts on insulin, there is a massive redistribution of this potassium from intravascular compartment to the intracellular compartment, which sudden market severe hyperkalemia. So this potassium is must. Only initial serum potassium is more than 5.3, I'm not giving my potassium to the patient. This is very, very important. Only potassium has fallen below this level, will start my patient on potassium replacement. So above 5.3 initial potassium, no potassium chloride. If there is a serum potassium below 3.3, put the patient on center line, correct this as soon as possible with a increased dosage. And if the patient is 3.3 to 5.3, this is the most of the times we encounter the normal serum potassium in the initial level. So the every liter of fluid which you give, you need to have 20 to 30 milligram of potassium chloride included in this patient. So I have given the with this replacement, even you are putting the patient on 20 to 30 milliequivalents in each liter, it may result in a dramatic fall in serum potassium once the insulin administration starts due to rapid distribution. This is very, very important. You need to have a potassium monitor very rapidly or very frequently also, like every 2 hourly you need to monitor the potassium, especially in the initial hours. You need to be very careful if the patient is having a pre-existing renal disease, like if the patient is having an acute kidney injury or a chronic kidney disease, patient may have hyperkalemia in these patients. So you need to monitor these patients for the hyperkalemia also, which can end up in very disastrous thing. So as I said you, the first thing is always fluid. What fluid? As I said you, the isotonic crystalloids, that is either 0.9% NS or RL. How much fluid? If the patient is in shock, I want to give 30 ml per kg as soon as possible. If no response, give the bolus. If no response, start the patient on inotropes. If there is a response, shift the patient on maintenance fluids, that is 15 to 20 ml per kg. And keep on monitoring the patient. And potassium level, see if it is more than 5.3, don't give potassium. If it is between 3.3 to 5.3, every liter of normal saline which you give to the patient, you add potassium chloride 20 milliequivalents in that. And if the serum potassium is below 3.3, always correct the potassium in a rigorous way. The next thing is insulin. So the cornerstone of DKA, because of the basic physiological process and absence of insulin secretion or its so we want to give insulin to our patients. So all patients of our DKA should be in therapy as soon as they diagnose, along with the fluid resuscitation. As I told you, the patient, as soon as you diagnose them with DKA, to have 2 large bore cannula inserted to those patients and start fluids rapidly, and in one cannula start the insulin infusion. The only exception is if the patient has initial potassium below 3.3, you don't start patient on insulin therapy because it may end up in a very fatal thing where patient may die suddenly because of a severe hypoglycemia. This is the very common mistake till now which occurs in emergency. Without seeing the initial potassium, the patient will get started on insulin, or like patient, they're getting shifting from one hospital to another hospital. The patient blindly they start patient on insulin without checking the potassium, which may end up in your emergency in cardiac arrest. This is very common. So if you want to help a diabetic ketoacidosis patient being in a case of primary care or a secondary care hospital, just give them IV fluids, which is more than sufficient. Don't give any insulin. Don't give any bolus dose. Don't give any insulin infusion these patients. Many of the patients get shifted from one hospital to another hospital in insulin infusion. This is very, very wrong thing, because patient cannot die of hyperkalemia when the patient is on insulin. It's negligence on the doctor. So insulin therapy is a cornerstone. Every patient I'm going to give insulin in case of DKA, except in a case of severe hypokalemia, where first I will bring the serum hypokalemia, serum potassium level above 3.3, then only I will start this patient on insulin therapy. So we have decided the patient on insulin therapy. So what type of insulin we have? We know that many types of insulin which we are having in the market. Which one we should go? How give insulin? Whether we are giving bolus, we are giving subcutaneous, we are giving IV, we are giving oral, we are giving nasal. How we should give, and what is the dose? That is what you should remember here. It's very easy to practice and very easy to write in exam also. So what type of insulin we are using here? We are not using any rapid acting, any long acting insulin here. We are using only short acting insulin. And in short acting insulin, we know that there is a regular insulin and there are rapid acting insulins, like we have got Lispro, we have got Aspart, etc. So the regular insulin is the choice of insulin here because of cost. See, the Aspart, Lispro are very costly. Till now, it is not available in the government sector in many parts. So the regular insulin is pretty cheap, pretty available, and there is for intermediate and long-acting insulin. You cannot give NPH infusion, you give Anion infusion, you cannot give Detimer infusion. The only insulin is so the order which you give, or you follow in case of diabetic ketosis management is regular insulin. So how you want this regular insulin? Whether you want to give subcutaneous or intramuscular or intravenous. See, the subcutaneous absorption which you usually give of normal channels is usually reduced in case of diabetic ketoacidosis because of a very severe dehydration. The skin perfusion is lost in these patients. So the amount of absorption is very erratic. You cannot predict the amount of absorption in a subcutaneous way while you give. So the preferred mode is always intravenous and a continuous infusion. So you are giving this regular insulin via intravascular in a way of continuous infusion rather than the frequent bolus doses, because of a predictable response in case of continuous infusion, which is very easy to monitor and it is very easy to prevent hyperglycemia here. So you are going to order your patient continuous infusion. So what is the dosage? IV bolus followed by an infusion. So this is what the criteria says. Everybody is following this particular what we call guidelines. So as the patient diagnosed and you are seeing the potassium is more than 3.3, you are giving order to put your patient on, you give 0.1 followed by a continuous infusion of the same dose, that is 0.1 unit per kg but per hour. So if a patient of diabetic ketosis is 60 kg, the order goes like this: injection regular insulin 6 unit, that is 0.1 per kg. So for 60 kg, 6 unit I stand. This is for 6 units per hour continuous infusion. This is what you are going to put patient on. This is very, very important. And while putting this patient on this 0.1 unit per kg, keep on monitoring for blood glucose and serum potassium. Any time during the continuous IV infusion, if the serum potassium goes below 3.3, you need to stop the patient on insulin right away, bring the potassium to normal level, then restart it. The protocol goes on. And the optimal rate of glucose decline with this amount of insulin infusion is usually 50 to 75. If you are not seeing this amount of glucose decline, you need to increase the dosage. Allow the blood glucose to fall below 200. This is very, very important. especially in the first 5 hours. Don't expect your patient to have a hypoglycemia. If the patient is have hypoglycemia in the initial 4 to 5 hours, the risk of cerebral edema increases very commonly, which is one of the deadly complication, especially in case of pediatric population. The only thing which I don't want my patient to go on in case of diabetic ketoacidosis is on cerebral edema. It's very difficult to treat. The mortality becomes very high in this patient. And another entity is hypoglycemia delays the correction of this ketoacidosis. Very, very important. So insulin, as I told you, the dose which we do give diabetic ketoacidosis is 0.1 unit per kg stat. This is followed by a 0.1 unit per kg per hour. I have put a question mark in front of bolus dose because there are a lot of question nowadays the efficacy of the bolus dose. Many of the people state that there is no need for bolus dose. In fact, many of the emergency physicians or endocrinologists also believe that this bolus dose is a risk factor for cerebral edema, especially if the patient is thin weight or if the patient is fragile or if the patient has not eaten anything. It may cause a severe hypoglycemia and land up in increased risk of cerebral edema. But even the latest guidelines includes the bolus dose. So till now we are using the bolus dose for a continuous infusion. But even if you don't give any bolus dose, there isn't going to be any change in the what you call outcome. The outcome remains same. Put the patient on 0.1 unit per kg per hour. So the fluid we want to remember is 30 ml per kg in case of shock, 15 to 20 ml per kg in case of the replacement volume per hour. And potassium, I want to remember you less than 3.3, 3.3 to 5.3, and more than 5.3. And insulin 1 unit per kg bolus dose followed by 0.1 unit per kg per hour infusion. So you have started this patient this on insulin. So what to do next? Give the patient orders as monitor blood glucose every 30 minutes or every 40 minutes or every 1 hourly. As soon as the patient reaches blood glucose of 200 milligram or below, in any time during your monitoring, if the patient goes below 200, replace this normal saline with the dextrose containing saline. This is very important. Otherwise, the patient will be receiving only normal saline and insulin infusion. So there is a risk of hypoglycemia. Now you want to balance your insulin infusion with the dextrose containing solution. And simultaneously, if the glucose is consistently below 200, you can attempt to reduce your insulin infusion at the rate of 0.02 to 0.05 units per kg per hour. So the basic concept here is, as soon as the blood glucose comes below 200, shift the patient from normal saline to dextrose containing solution. And if the patient remains blood glucose less than 200, try infusion. And this protocol, in this protocol, we need to have some few questions to be answered here. Many of the people believe that if the patient has mild DKA, we don't want patient to put ICU because of a cost issue. So we want the patient to be managed in a regular wards on subcutaneous insulin regimens. So many of the people believe that in case of mild DKA, instead of a patient going through this continuous IV infusion, the use of subcutaneous insulin is pretty equal. As soon as they become moderate or severe, it is prudent to shift back to them ICU. But this has not been given approved anywhere, only because in resource less settings, or in a case of COVID pandemic where the resource was very low, the patient load was very high. Even we, during the time of COVID, we have managed the diabetic ketosis in a regular ward. It was inevitable because of lack of availability of beds. And insulin analogs, we have got nowadays a lot of analogs along with the human insulin. So nowadays, or till now, the insulin analogs have not been approved for the management of diabetic ketoacidosis. Only the rapid-acting insulin analogs, in case of the cost factor is not involved, like in a high what you call socioeconomic status, the rapid acting insulin can be given as PET, can be given as IV, whereas in case of the government sector or many of the parts of world, we are still using the regular insulin only. If you don't want to remember extra, just remember regular insulin. It's now metabolic acidosis. We know that there is a huge there is a bicarbonate deficiency in case of the diabetic ketoacidosis. But remember the first corrections, like as soon as you correct the patient with IV fluid and insulin, the metabolic acidosis and carbonate is going to settle down on its own. The acidosis is trying to resolve very slowly. As soon as you're giving the glucose to the patient, the ketoacidosis, the ketone production reduces, and you are giving insulin, which also reduces ketone production, and by reducing the fat breakdown, the body tries to maintain the homeostasis. So in a patients of mild to moderate DKA, we're not giving the patient on bicarbonate therapy because if you give a bicarbonate for these patients, the compensatory mechanisms get altered. So this might reduce the respiratory drive, which might cause the hypercapnia in these patients. And the administration of alkali also has shown to slow down the rate of recovery of ketosis. And alkali administration can also lead to post-treatment metabolic alkalosis. And another very important thing is bicarbonate infusion by itself can cause hypokalemia in patients. So we are not routinely supplying our diabetic ketoacidosis patients on bicarbonate, but we are giving bicarbonate less than 6.9, that is a severe metastasis. pH of less than 6.9 is very difficult to be compatible with life for the cells. So only if the pH is less than 6.9, I will give the patient on bicarbonate therapy. So this above indication is not an evidence-based, but a pure expert opinion, because many of the people believe that if pH is very low, like less than 6.9, which will reduce your cardiac contractility and tissue perfusion. So we don't want the patient to have extra acid load. So the correction is advised here. So the correction which we usually follow in case of diabetic ketoacidosis here is 100 milliequivalents of sodium bicarbonate in 400 ml of sterile water. The potassium is, again, as I told you, bicarbonate infusion is going to cause a hypokalemia. You need to add this patient on potassium chloride if the potassium is less than 5.3. Wrong here, the potassium is 5.3. So the only indication of bicarbonate supplementation in a case of diabetic ketoacidosis is a pH of less than 6.9. This is an entrance question. This is a question of Viva OC in case of both postgraduates and undergraduates. In case of the other indication of bicarbonate, which you should remember, is in case of an acute kidney injury induced metabolic acidosis, where the criteria is 7.1 according to Harrison or according to even KDIGO, whereas in case of diabetic ketoacidosis, it is 6.9. Serum phosphate, again, we are not routinely supplementing our patient on serum phosphate. Only if we encounter severe hypophosphatemia, if the serum potassium is below 1 milligram or below 3.2 millimoles per liter, only we are going to give 20 to 30 milliequivalent of phosphate, either a sodium phosphate or of fluid. Otherwise, routinely we are not supplementing the patient on serum phosphate. So the very most important aspects of diabetic ketoacidosis management is, one is fluid resuscitation, another one is insulin therapy, next correction of acid-base imbalances, correction of electrolytes, and again the treatment of precipitating causes is very, very important. So to revise very fast, fluid resuscitation, the fluid of choice is NS or RL, preferably NS. If patient is in shock, I will give 30 ml/kg in shortest time possible. If the patient is not in shock, 50 to 20 ml per kg, I will give in the first few hours. And if the patient's potassium is less than 5.3, I am going to give 20 to 30 milliequivalents of potassium in every 1 liter of fluid. If the potassium is less than 3.3, then I am going to give patient potassium very rapidly. If the patient is having potassium of more than 5.3, then no need to give potassium. The type of choice is regular insulin. insulin stat followed by 0.1 unit per kg per hour infusion. And I keep on monitoring the patient. As soon as the blood sugar comes less than 200, I shift the patient back to dextrose containing solution by simultaneously trying to reduce the insulin infusion. So monitoring, as I said, is a very, very important thing. The blood glucose to be monitored every hourly because of the risk of hypoglycemia as the patient is on insulin infusion. And the serum electrolytes, the blood urea creatinine, and the venous pH are to be monitored as soon as possible, preferably every 2 to 4 hourly. In many government hospitals, it is very difficult because it usually takes 2 to 3 hours to get reports of electrolytes. Whereas if we have a point of care testing ABG machine, it is very easy to get the electrolytes. And it is strongly suggested to use a flow sheet of lab values and clinical parameters for better visualization and valuation. Even in my particular hospital practicing now, we use a flow sheet to monitor the patients. So this is a particular flow sheet. It's very easy to follow. It's very easy to advise also. When you just see the chart, you will get to know at what stage of disease the patient is going through and what are the changes, what are the basic changes which you are going to do here. Now there is a criteria for resolution of DKA. You are going to tell that your patient is out of DKA only when your serum glucose is more than 200. Serum glucose because reaches less than 200, and if serum bicarbonate reaches more than 15 and pH is back to normal, that is more than 7.3, and anion gap is less than 12. This is the ADA criteria. The basic criteria goes like this. The resolution of DKA is considered when the serum glucose is less than 200 along with one out of these two conditions. Either serum bicarbonate is more than 15 or pH is 7.3 or anion gap becomes normal. And the surrogate marker of successful fluid resuscitation. Another question is till what time I will give the patient on keep my patient on IV fluids. Till the closure of anion gap, you will keep your patients on IV fluids. Don't start the patient on oral medication before anion gap settles down. Only after anion gap is settled down, you will start the patient on oral things. Another very mistake which we usually do is shifting the patient from IV insulin to subcutaneous insulin. Even when I entered, nobody teaches these things. So here I have got a very particular thing how to shift your patient back to regular insulin, back to subcutaneous insulin. So when to shift the patient back to subcutaneous insulin, especially in case of type 1 diabetes, patient is able to eat. If the patient is not accepting orally, if the patient is not able to eat, you cannot take this patient on subcutaneous insulin. Only after patient is stable, is telling now they start the patient on this conversion. Which regimen? We have got a lot of regimens, premixed regimens, etc. But the regimen which to be followed is only basal bolus regimen. Many of the doctors or hospitals or postgraduates shift the patient directly from IV insulin to premixed insulin, which is very wrong. Always take these patients on basal bolus regimen. That is a physiological regimen. Only in after taking physiological regimen, home you can patient on premixed insulin. But the basal bolus is how to do it? The best time is before a patient is free. So before the patient takes first meal, after for this IV infusion, then after gradual tapering, the continuous IV infusion. So when the patient takes, yes, I am ready to take a meal, decide the meal for the patient, give the rapid